Why use ultrasound guidance? There's a lot of talk. There's even been, some studies, some articles written about whether or not ultrasound is the new stethoscope. If you look at the word stethoscope, scope actually means to look. But as we all know, stethoscope only allows us to listen. The beauty about ultrasound is you're actually able to see inside the body, get a better sense of what's going on. And thanks to technological advances, they now have ultrasound machines as small as a handheld device that you can actually fit into your white coat pocket. So what does the literature show? Studies show that ultrasound-guided injections are more accurate than clinically guided injections, even among very experienced physicians. One study showed that only 29% of clinically guided injections for subacromial bursitis actually reach the intended bursa, so we're not quite as good as we think we are. So for procedures, the main advantage of ultrasound is you're actually able in real time to see your target and avoid structure you would want to avoid, such as vessels or nerves. So you might be thinking, okay, ultrasound-guided injection, it's more accurate, but does it improve the clinical outcome? And the answer is yes. So one study, randomized control study, addressed whether ultrasound-guided injections affected the clinical outcome, looking at intra-articular joint injections. They looked at 148 painful joints. They were randomized to get a steroid injection, either conventional palpation or ultrasound-guided. They looked at baseline pain, procedural pain, pain at outcome, and change in pain scores using the visual analog scale. And what they found was relative to conventional palpation-guided methods, ultrasound guidance resulted in 43% reduction in procedural pain, 58% reduction in absolute pain scores 2 weeks later, 75% reduction in significant pain, 62% reduction in non-responder rate. In addition, the ultrasound allows us to increase detection of an effusion by 200% and volume of aspirated fluid by 337%. So this study concluded that ultrasound guidance definitely improved clinical outcomes. So more studies. Another study here looked at 2 randomized controlled trials that met criteria for pain, function, and adverse events. Meta-analysis demonstrated greater improvement at 6 weeks in both pain and function. However, we do need more adequately powered trials. So when we look at the knee, suprapatellar bursa injection, common injection we do in the office all the time, seems relatively simple. You can see in the image over there. This study looked at 99 patients with knee arthritis. 50 got ultrasound-guided injections, 49 palpation-guided injections using the suprapatellar bursa approach. They were all injected with hyaluronic acid and contrast. So the contrast actually allowed us to see whether or not the hyaluronic acid made it to the intended place. And what they found was for those who got ultrasound-guided injection, it was 96% accurate. A palpation-guided was only 83% accurate. So, that is a significant difference. Another study looked at shoulders. They had 80 cadaver shoulders injected with contrast. 40 got those under ultrasound guidance. 40 were injected blind. And what they found for ultrasound guidance, 92.5% accurate. Blind injections were only 72.5% accurate, so much less accurate than with the ultrasound. Again, we're showing that it's definitely far more accurate. This study here was just looking at many different joints, looking at palpation-guided versus image guidance, and overall what it's showing, when you start getting down to some of the smaller joints, such as the elbow and the wrist, if you don't use any kind of guidance, you could be very, far less accurate, anywhere 25 to 38% accurate, so definitely not as good as we think we are. So what are some of the technical considerations? So a couple other things you have to think about if you're going to use ultrasound guidance in the office. The most important rule, I think, is that you need to know what you're looking at before you stick a needle on it. So you need to know anatomy, you need to know ultrasound anatomy. You want to make sure you don't hit anything on the way to your target that you shouldn't, such as nerves and vessels. You need to know sterile technique with using your equipment. You need to have reasonable skill in handling the transducer and reasonable skill in driving the needle. So a couple extra things you need to think about in terms of sterile technique when you're using ultrasound machine. When you do skin prep, you want to make sure you do a wider prep than if you weren't using the ultrasound. So you could use the chlorhexidine, or you could use betadine, and Dr. Sethi went into why one would be better than the other. You want to make sure you do a really wide prep. So anywhere the probe's going to go, anywhere the needle gel's going to go, you want to make sure that's covered. There's special disinfectant for both the ultrasound probe and the cable. When you purchase your ultrasound machine, the company usually will tell you, the appropriate disinfectant. The probe itself has to be kept sterile. So in the office, we cover the probe with Tegaderm. There are also special probe condoms that you can use as well that covers not only the probe but the cable. There's sterile packets of gel, so each patient you're going to be using a sterile packet of gel, and they come in 20-gram packets, which you can see in the picture there. That's usually sufficient. The ultrasound also comes with an option of a foot pedal, which is really nice. So you're doing an injection, you have one hand you're holding the probe, the other hand you're holding the needle. You want to take a picture, you have a foot pedal where you're actually able to take pictures and save images while you're doing the injection. So when doing the injection, there's two approaches for doing the injection. One is called a long axis or in-plane approach, and that's where you're actually able to visualize your needle the entire time. So this is an example of the suprapatellar bursa injection that I was talking about. So in ultrasound, bright white, that's dense. So bright white here, that's the patella. Up here, that's the quadriceps tendon. The black here, that's an effusion. And the needle, that's directly parallel with the transducer, so you're actually able to see it quite nicely here. So you can see the needle is right where that effusion is, so you're actually able to aspirate off all the fluid prior to doing an injection. The other kind of injection is what's called a short axis or out-of-plane injection, and that's where you're not able to directly visualize the needle the entire time. This is most commonly used for some of the smaller joints. So when you're doing small joints in the wrist, hand, or foot, it's much easier to do this approach. And that is where you're going to line up the ultrasound probe with your target area. So this is an example of an acromioclavicular joint injection. The bright white, that's the joint. You can see the needle shows up as this bright white or hyperechoic dot right in the center of your target. While you inject the medicine, you're going to see that joint kind of distend, so you know you're in the right area. So quickly, I'm just going to go over an example of an ultrasound-guided injection, hip joint injection in particular. Hip joint is one of the more deeper joints that we inject using ultrasound. Deeper structures are a bit more tricky to see. It's a bit more tricky to visualize your needle. Anytime you're going on a steep angle, it's easier to lose your needle. The superficial injections are much easier. Again, you need to have a very clear understanding of anatomy before you do these injections. So before you start your injection, you have to pick your ultrasound probe. And the ultrasound machine comes with 3 different probes. For the deeper injections, such as the shoulder, you're going to use the low frequency or curvilinear probe. Some of the more superficial injections, like the shoulder, you're going to use a linear or high frequency probe. There's also the choice of what's called a hockey stick probe, and that's a very small footprint probe, and that's great for small areas such as the hand and the ankle. For the hip, we use the long axis view, so you're able to see your needle the entire time. Patient lies supine or head up. Usually a 22 gauge 3.5-inch needle, spinal needle, would be sufficient. However, if the patient's a bit larger, you might need to use a 5-inch needle. And prior to the injection, you want to make sure you anesthetize or numb the area well. So usually 5 mLs of 1% lidocaine, you want to make sure you numb the skin. You're going to numb the track along where you're going to put the needle. So this way, when you're going with that bigger spinal needle, it's much more comfortable for the patient. So in this picture here, that's an example of a hip joint injection. Again, it's the longitudinal approach where you're seeing your needle the entire time. Most of the ultrasound machines, they come with a Doppler, so that's where you're able to turn it on and look for any kind of vessels. So you can see in this picture here, you turn the Doppler on, it shows up as this box, and you want to drag it along the whole course you're going to be putting your needle just to make sure you don't see any vessels there. So right here, you can see that femoral artery lights up with the Doppler on, so you definitely want to avoid that when you're doing your injection. Patient might twitch when you enter the hip capsule. That's because it could be a little bit uncomfortable. And you're going to watch for the capsule to slightly inflate with the injection. There shouldn't be any resistance. If you're not quite on target, you might have to readjust your needle. So again, on ultrasound, bright white, that's dense things such as bone. So that's the femoral head, that's the femoral neck. The head-neck junction, that's your target for the hip joint injection. Here you even see the labrum nicely. So you turn your Doppler on, you want to make sure no vessels are in the way. And here you can see the needle shows up quite nicely, that bright white line. And you see you're right at your target of that head-neck junction. And the beauty of the ultrasound is that you're actually seeing what you're doing the entire time. So I just wanted to show a video of the injection. And you can see the femoral head-neck junction. Again, the deeper ones, it might be a little bit more difficult, but that's the needle, and you can see the medicine flows in quite nicely, so you're seeing the entire time what you're doing. So in conclusion, ultrasound-guided injections definitely improve safety, outcome, and accuracy.